a vision, and a space where connection, practice, and progress converge. Together we share knowledge, debate emerging science, and explore practical solutions suited to our realities and cultures. Our discussions here have always sparked innovation, and I have no doubt that this year's session will continue that legacy. I extend my deepest appreciation to our International Vice President, Chairman of the MP Shah, Dr. Manoj Shah, for his vision and the support in implementing these multidisciplinary diabetes care centers. As I said, not only at Lions Hospital, not at MP Shah, but many have gone around the world. I wish to applaud the organizing committee, the clinical teams, the researchers, and our partners of the Lions Site First Hospital and MP Shah Hospital for your tireless commitment. To all participants, Asante Sana for lending your expertise, your curiosity, and passion for this course. Let this ninth year not only mark our growth, but reaffirm our purpose that through collaboration and compassion we can outspace diabetes one time at a time. I end this with a powerful quote: strength of the pride is the each lion, but the strength of each lion is the pride, which is so synonymous with the theme of today's symposium, the power of connection, and embodies the strength of each one of you in this room. Thank you, and wishing you a wonderful deliberations, and God bless you all. Thank you.
Thank you, Chairman, for those wonderful and inspiring words. They have been a source of inspiration and support for our team through all the ventures that we undertake. It is now my privilege to introduce our chief guest of this morning. I would first like to just make a mention that in the print, there has been a little bit of an oversight on her leadership. She is a past chair of the Kenya Medical Practitioners and Dentists Board, not the current as it was. So I would like to make that correction. Apologies, Dr. Jenga. It is with great pleasure and deep respect that we welcome Dr. Evan Jenga, a distinguished endocrinologist, visionary leader, and passionate advocate for quality healthcare. Dr. Njenga has dedicated her career to advancing medical excellence, promoting compassionate patient care, and shaping health policy. As chair of the NCD Alliance, we are honored to have her here with us today, and we look forward to her insights, her wisdom, and her continued contribution to the growth of healthcare and leadership in our nation. Please join me in extending a very warm welcome to Dr. Evan Jenga.
I think it's still morning. Good morning, everybody. Habari zenu. It's really an honor and a privilege to stand here and share a platform, share a forum with so many colleagues and really great people who have made an impact and who continue to make an impact in managing both type 1 and type 2 diabetes. As I listened earlier to Prof. Konyiha and to Dr. Bogo and her team, I just felt proud. These are people, we have come so far. Kitida, you know where we started. We didn't have pediatric endocrinologists. This far we have come. And we really are grateful to God that we've got professionals that are moving in strides to bring better care. And I want to thank the organizers of this conference. It's the 9th for Lions. And team Riwan, I know she has gone out, and her team, Avi, and the whole group. You know, the way you coined the theme, I'm really, really happy. I'm thinking at it about the power of connection. What I looked at, I'm looking at this team here, connecting with that team there, who are the professionals, the team, the community, the patients. But I just wanted to ask, maybe I'm very polite, maybe I'm a bit ignorant. Do we have patient groups in this workshop? Do they have a slot in your program? Because after all, we are connecting them. Do we have? Anyway, you don't need to answer that because I didn't see them in the program. I'm just raising an issue because this is a fantastic theme. And empowering the people we are connecting is so vital. Completing this whole thing would have been a table here of people living with type 1 diabetes, people with diabetes, support groups, so that they can start here and tell us their opinion of what we are doing. Because after all, we are serving them, isn't it? We need to hear from them. But I know in other groups, like during the food workshop, you had people talking about it. So this is the first thing I want to bring out when we're talking about connection. But the theme is so critical. And connecting, that power of connection, what do you get by connecting as we connect here? For us, it gives us accountability. It makes you realize that Kenya Diabetes Study Group can call you out when you are mismanaging a patient. And we can call each other out. I like the Kenya Diabetes Study Group because I see a number of colleagues posting challenges and challenging patient care questions, and we share. One person whom I really admire and who is so good is Dr. Sokwara. Sokwara posts and posts. She never tires. These are the kind of things that I like to see people connecting, because you definitely cannot know it all. It does not matter how many years you've been schooled. Doesn't matter how many workshops you've gone to. It does not matter whether you have the PhD or whatever certificate. You cannot know it all. You always need to learn. When you talk to Gaman, every day I learn about CGM. I've just learned something about FDA approved and other CGMs, and why we need to be careful what we are accepting in the market. Just talking to him a few minutes ago, that's the power of connection. When we share information, we start being accountable to how we practice medicine. You cannot say that you cannot cannot educate your patient, you can't give your patient nutritional advice when you have specialists in this group who are just a phone call away. So that phone call, you heard how Professor Kunyiha got people managed and just by a phone call. And it is so important at whatever level. And then the other thing that we also need to connect with are the health policymakers. We can have all the data. We are health professionals. We cannot drive how SHA is implemented. But if we had Ministry of Health people here, or people who are policymakers, they need to hear our passion and how committed we are. Why are we asking why is Joyce saying about basal bolus? And why is she saying she's not satisfied for type 1 by FASIC or mixed insulins? They need to know, so that when we are doing that, essentially we are setting to level 1, level 2, where SHA will be implemented. Do we have these insulins? And I know we don't have. So for the gentleman who was saying, how about mixed? So let's help each other. How, if you are in a place where you will not get basal bolus, and the basal bolus doesn't have to be Revimir and Novorapid only. You have all the other insulins which you can use, and the endocrinologists, diabetologists can help how you tailor the doses, how you convert from maybe a Revimir to NPH. So this is the power now of connection. This is how we learn from each other. So if you are in a place where there's nothing else, you will not say, because I don't have a basal bolus, I can't manage my patient. You will need to know how to use what you have to keep that patient alive until you can get to another level where they can afford the basal bolus. So it is important for all of us to know all the levels of managing a patient, starting from education, starting from lifestyles, and so forth. So I come back to the power of connection. When we connect, you're connecting with the psychologists, the social workers. We address mental health at an area of health that is mismanaged and forgotten for people living with NCDs. And I think some time next week, we are going to be having a big NCD, the first NCD conference in this country. One of the things is talking about breaking silos, whereby we all don't think where we are is the most important thing and you ignore the other specialties, so that you know that you cannot succeed keeping in my clinic with Dr. Minor, and we forget Betty Okere, other nutritionists, we forget the diabetes educators, we forget the food care people, the specialists. We do not refer to ophthalmologists. We don't get our patients seen by the renal people. We don't get our patients seen by the cardiologists, and you still think you are managing your patient well. That is why power of connection. This needs to go. We need to speak loudly. We need to shout how important this theme is and how it reaches people. And it doesn't just need to come into conferences or even if I'm patient. Digital health, telehealth. We can no longer be ignorant. And I'm happy that most of the regulators ask for CMEs. And it's going to come to a point whereby your CMEs are relevant to what you practice. If you're a nutritionist, you need to show me how many nutritional conferences and workshops you've attended and participated. If you're an endocrinologist, you don't go and attend a surgical CME and you come and claim those CME points. You need to attend relevant CMEs, and that is what almost all the regulators are in agreement now. Because that way, you connect, you cannot be in denial that you don't have access to information. And again, I like this. You will be able to, somebody said that 15-year-olds are very clever. They have Dr. Google. They get all the information. You think that you are telling them something new, and they will shock you with the questions. So please, as our educator said, calm down, bring yourself kidogo chini, listen to them, because they have also a lot to offer to you. And by listening to them, you actually start to realize where their issues are. And that's also then that gives you the correct way to refer. Because when you listen to them, they'll come and tell you, and you said they will be able to tell you what you want. They already know your diabetologist wants to hear, this is what you have done and your sugars are this. So they will bring those sugars. And some of them, that's why they don't want CGMs, because the CGMs will call them out. Because if it's recording, they can record the best sugars and take a picture and send you that book on your WhatsApp. They are fantastic at that. So then you are wondering, the HB1C is showing 12%, but all these sugars are below 8. What is happening? Of course, then you know you are being played. And these guys are they are so clever. They manipulate you. So you need to listen. And because when you start actually listening, and Dr. Bogo said, you start suggesting things, you are not judging, they start opening to you and they realize, actually, this is my friend. So you need to become their friend for them to share so that you can manage them better. Again, that is the power of connection. So we need to have that power to connect properly, because you can connect very badly. You can connect by judging the patient, giving them the wrong information, not listening to them. That is still a very bad way of connecting. So we need to learn what is good connection, what is impactful connection, and what is going to help your patient. So it is this workshop. I've looked at all the sessions that you are going to discuss today. I'm really, really impressed. And I think what our takeaway message here is putting patients at the center of everything, whether it's CGM, whether it is talking about the things that have already been presented today, whether we are talking about health equity, learn whether they are from urban or rural, whatever it is, their level of education, all these things that Professor Kunia took us through this morning. It will guide you. It will enrich and empower you to help that patient. And where you do not know, please admit, we don't know everything. Just admit that you don't know and called Dr. Asharia, called all these other specialists and asked, I'm stuck here. You're not going to be judged. I think when somebody calls and says, I have a patient, I'm struggling, I really admire the colleagues who do that. Those to me come to the level, that level, and I praise them very high level. But when you get a patient and they say they've been managed in a certain clinic, but those people have never asked for help, and the patient is so mismanaged, then you know there's a problem there. And I think this is where we need to hold each other accountable, not judging each other, because sometimes also it depends on how much knowledge is exposed to you. But I said we have no limitations to get information. There's always CMEs going on. And if you're not a member of KDSG, talk to members of KDSG and they will let you know when these CMEs are going on. Trainings, whenever you can, get into trainings. Because again, when you get connected, you get information, and information empowers you. So the various courses that you get trained in, again, help you to bring people together. You get your practice better, and you progress in the way you manage your diabetes. At the diabetes people, the thing is, somebody said and puts a whole breadth thing that the patients, the lifestyle becomes the middle of everything. You as the diabetes specialist or the nutritionist or the educator or whoever it is, you can't do this alone. Your patient is in the middle. And I can tell you the problem is the cost of giving care in this country, especially specialist care, is very expensive. But we have associations and organizations and societies that are offering this same level of care at some of them free. DMI has not only just giving the surprise, you are told they have educators, they have psychologists, they have the nutritionists, they have everybody, and they know how to get in touch. They will connect you with the food specialists. We have all the wood care managers, they come and help. I know at some point DMI even negotiates with the dentists to see our patients for free, because then diabetes patients also need to see dentists. We also have ophthalmologists that see patients from DMI for free. So you just need now to know that this is available, and that is by connecting, and that's by calls, taking a phone call and finding out, can you help our patient? So those patients who cannot afford, and there are many, let's get them forums where they can get exactly the kind of help we are talking about to get quality care. So this is, again, power of connection. So I would like, even as we come out of here, let's get numbers. Let's talk to each other. I would want to know about all the diabetes educators, where they are, so that even in my clinic, I know the farmer out there, they are offering, some of them are offering their trained nutritionists and educators to come round to our diabetes clinics to help our patients for free. They are not charging. So if you have that information, make use of it. So the people who are out there in these exhibition halls, they also have a lot to offer. And then we talked about the media, the power of media. Whenever you get a chance and you are called to talk to either your FM, the vernacular FM, or to whichever, please talk to people about facts. And the thing is, there are so many people now who are going out there. Most of them are con. Have you seen what, like Professor Konyi has said? I've seen one that mimicked Dr. Gikonyo, the cardiologist. I think it was in the KAP, it was posted, where it was shared that he has said he is curing diabetes in 3 months, that all the endocrinologists and diabetologists are liars. And you can see it as it's him talking and saying these words. Of course, these things are being crafted by AI. The more we are advancing digital and telehealth, the more we are going to get con people. So stay alert, help each other. And I know even in KDSG, whenever a video is posted about one of us, even Gaman at one point was posted saying something about, I think, one of the cures of diabetes. I think these new products, we need to know. And believe you me, I'm not judging whoever is making this, but we know people are trying to make money. And everybody, and they see somebody who is a prominent like Dr. Gaman talking about this, and we know he has all this knowledge. Of course, you go quickly and try and buy that product. and that these products are not cheap. So we need to have that information out there. So whatever forum you have, whether it is your church group, whether it is whatever you are in your marketplace or your chama, talk to people about information, because I can tell you, especially now for obesity, the things that are being circulated. So again, the power of connection with correct information, empower people, then you are safe, you are held accountable, you are empowered, and you protect your patients, you protect each other as colleagues. My duty is to try and make sure if I hear somebody talking bad things about Dr. Asharia or Dr. Liwan here, I'll be the first to step out and say, I think you got the wrong information. Because I know these young people here. Some of them I've taught. So I know. Some of them have worked together. So I can step confidently and say, you are wrong. Even patients who come and start, most of these people don't know that I know all of you. I've been seeing so and so, she is this. I said, tell them, stop. The person you are describing is my very close friend. So can we start again? And then we start and say, you know what? We are starting today with this. And then you tell them, I would actually want to refer you back to the person where you have come from. These are the things that we have to be proud of. If you're going to be a professional of any ethical grounds, you need to stand out and say these things. Not swallow everything. Also, a patient comes and tells you about your colleagues and start saying, yeah, I agree. Actually, this was very wrong. The minute you do that, let me tell you, the next week, they're going to be moving to another colleague and they'll be saying what Dr. Jenga said. So don't think you are safe by trying not to protect each other. So we protect, and this is what we are talking about, connection. So the connection gives you the power of accountability, empowering you with proper knowledge and supporting each other, because all of us also need support as professionals. We get burnout, and you need to start learning when colleagues are getting burnout. Some of them working in institutions where they have such a long queue, they get burnout. So we need to reach out and see how can we help. So the power of connection is not just here at the Lions Hospital in the conference. It's not for just today. It has to be continuous. It has to be to leave an impact, and we have leave some legacy, all of us, wherever we are. So today, I'm really happy to be part of this. And I don't want to take so much time because I know we have more important topics to discuss. But I'm so happy to have been part of this. The one always urging me to come, and I wouldn't need any persuasion to come to your conference. But I think it is it's such an honor for all of us to be part of this and to share. So my thing, what I would tell you is empower each other. I still remember at some point, Asharia used to say, knowledge is power. And so I'm feeling every time I get new knowledge, I'm empowered. And I feel very empowered today. So thank you very much. Enjoy your workshop, and hopefully that we all go home more empowered. Asanteni sana.
Okay, thank you very much, Dr. Eva Jenga. I'm standing here representing our chair. Gatherings such as this, we not only exchange valuable insights, but also strengthen the network of people and institutions, driving positive change in diabetes prevention, treatment, and education. So on the behalf of the Board of Directors and the entire MP Shah Hospital fraternity, I extend a heartfelt gratitude to the organizing committee for their dedication and the tireless efforts in making the event a success. Dr. Rilwan Aiden, head of the Diabetes Care Center at Lionside West Eye Hospital, Dr. Shilpa Mulki, Dr. Vinit Shah, Dr. Christian, and RF Kelsey, the strategists behind the Lions Diabetes Care Centers, your commitment and leadership continue to inspire excellence in diabetes care and community outreach. I would also like to express our sincere appreciation to our sponsors and partners whose continued generosity and support make these symposiums possible year after year. Welcome once again, and may the symposium be an enriching and inspiring experience for all, where every connection leads to a better diabetes care. Dr. Manoj Shah, the chairman of the MP Shah Hospital and vice chairman of the Lionside West Eye Hospital. As we start our next session, please allow me to introduce our session chair. This is a lady I've looked up to for many, many, many years, Dr. Nemera Maina. She's a general practitioner and runs the Diabetes and Endocrinology Clinic. She has over 20 years of experience as a general practitioner and is currently working in the Diabetes and Endocrinology Clinic. She is a member of the Kenya Diabetes Study Group. Please welcome Dr. Maina.
Good afternoon, everyone. Now, we have a slight change, so I'm going to call up Dr. Kirti Acharya, who's going to talk to us about precision medicine in type 2 diabetes. I've known Dr. Acharya for very, very long. I think she was an intern under me at Aga Khan Hospital. She has studied in the UK and in Kenya. She's a well-known diabetic endocrinologist who has vast interest in diabetes education, and in mentoring the younger medical students and also diabetic clinical officers, and basically all of us. Dr. Acharya, welcome.
Good afternoon. I can say good afternoon now. So I'm going to talk about the art and science of precision medicine in type 2 diabetes. When I was in Vienna very briefly with my colleagues, and Rilwan and I were sitting together, I told her, I think I'll talk about this at the next opportunity. So the opportunity came today. Thank you to Arv and the organizing committee for asking me to give a talk today. And yeah, it's a big topic, so I'll get started. How do I move the slide? Sorry. Yeah. Okay, so has anybody heard the term precision medicine? It's not a quiz. So when Joyce Bogo was talking about the gardener in type 1 diabetes in the morning, basically this is how we do gardening in type 2 diabetes. Basically every patient is different, and that's what I'm going to be talking about. So basically, with modern times, with AI, with the huge pharmacologic armamentarium that we have in type 2 diabetes, it's like when you're trying to get to your targets, it's like precision medicine is like looking for a needle in a haystack. But if you get it right, you can find the needle, you can stitch, you can sew, you can be a tailor. Basically, it's tailor-made medicine. So the journey of precision medicine in diabetes, it's not new. Basically, in the past, sorry, I'll need my glasses now. So in the beginning, when looking at type 2 diabetes, there were just two types. Everybody talked about insulin sensitive or insulin insensitive or insulin resistance when it came to type 2 diabetes. And then as time went on in the 70s, MODI came into into existence, maturity onset diabetes of the young. The reason I want to go through this is because if you get the diabetes wrong, you'll get the treatment wrong. Just for the sake of asking, has any of you ever worn shoes that are the wrong size because your mom gave you hand downs from your cousins or your siblings and had to walk to school with them? I have. It hurts. Have you worn clothes that are wrong size because you added weight or lost weight? We all have, right? It's embarrassing, it's uncomfortable. So when the diagnosis is wrong, because type 2 has subtypes as well, and the treatment is wrong, and glycemic targets are not achieved, that is imprecision medicine. I don't know if the English is wrong. And that's why I want to give this talk today. And that's why as doctors, as in patients, there is frustration when it comes to not achieving what you set out to achieve. So moving on, the historical calendar. Later on, type 1, type 2 diabetes. People right now are talking about 7 types of diabetes. I'm sorry, I'm not talking about type 5 diabetes. Some of you came here waiting for type 5. You know what type 5 diabetes is, right? The malnutrition diabetes. Please don't ask me questions on that. That's not my topic today. So I will be answering you on precision diabetes. And then later on, there is a LADA, which is between type 1 and type 2, the latent autoimmune diabetes. But basically, when you are looking at your patient and wondering why you're not getting to your targets and why you're not getting your HbA1c, it's not always that the patient is not taking your prescription. It's not always adherence and compliance. Sometimes you've got the size wrong. You've got the diagnosis wrong. You've got a subtype wrong. Okay? Type 2 is quite complex. It's not lifestyle disease. It's not about metformin. There is a lot more. It's a whole Pandora's box. Okay? So moving on, Rilwan told me we're running behind time, so I promised I'll walk faster. So precision medicine is all about optimizing your diagnosis. Number one, have you got the diagnosis right? Is this type 1? Is this type 2? Is this MODI? Is this LADA? Is even in type 2, what subtype? There are ethnic differences as well. The prediction and prevention, we know type 2 is preventable. The treatment, when you look at your prescription, the polypharmacy, DPP-4 inhibitor, GLP-1 analog, metformin, insulin, where are we? And in the lifespan of a patient, your prescription has to be dynamic. It keeps changing. So you don't have to copy paste a prescription because a professor or a consultant before you started a prescription. You have to be this curious person who's like, can we do better? Do we need to change something? Do we need to add something? Why is there no statin on this prescription? Could we add something else? Could we do better for this patient? This patient is obese and yet they're on a medication that's adding more weight for them. Could this patient benefit from a sulfonylurea? Or have we missed MODI? Have we missed this? Have we done that? Is this a phenotype? Is there an ethnic difference? Sometimes guidelines also have to be bent, twisted, broken. Okay? We have to integrate multidimensional data. Okay? So all this input has to keep happening. All right? So I'm asking you to keep always thinking about your patient. Have we got it right? Even if it's an insulin, basal bolus, sometimes something is slipping through the net. And we have to account for inter-individual variations. There are differences in every patient, okay? Their eating practice is different. Their stress levels are different. So there is everything that is happening, and unless you have a rapport with that patient, you're not going to know why something is not working. So personalized medicine, okay, tailor-made medicine, precision diabetes. So final step in the process of translating knowledge into the practice, and it emphasizes tailoring, gardeners, tailors. At the end of the day, as doctors, we wear many caps, friends, advocates, okay? And we have to come down from our ego castles, wherever we are sitting, down to the patient level. Communicate, don't say I know it all, do what I say, do not work by threatening, okay? And then you will get your precision medicine down to a fine art. This slide you're all familiar with, individualizing your care. So if you have a patient who has cancer, who has dementia, who can't hear you, getting your message across, what is your HbA1c? Your HbA1c may even change if your patient has sickle cell anemia or a hemoglobinopathy. It may not even be something you can interpret correctly. That is why you need the sugar readings as well as you look at the HbA1c. Somebody with renal impairment will not have the same targets as a pregnant patient as a type 1, type 2. So please individualize for every patient. We can't use blanket targets and blanket prescriptions for everybody. Patient-centered approach. The patient is at the center, and then comes the parent, the teacher, the employer, the county, the government, Trump, everybody. Everybody else later. The patient is at the center of your decision making. There are many patient factors that impact glycemic control, as there are prescription factors, as there are financial factors. I'm not going to have time to extrapolate on all this. Chantal Metho spent an hour at one of the ESTs, I think it was in Stockholm, talking about this patient-centered care. I don't have an hour, I don't even have 20 minutes, but this is a wonderful slide. So it's dynamic, the smart, achievable goals. But this is a bit of precision medicine. Care has to be respectful, okay, dignified when you're offering care, whether you're doing it for free or you're doing it in a limited time with 200 patients waiting outside. It doesn't matter whether you're in private sector, public sector, you know, that little bit of dignity, a lot bit of dignity, how you communicate with your patient, language barriers, cultural barriers, it's very important. The glycemic pentad, I've talked about this in previous, everybody talks about the triad, HbA1c, fasting sugar, postprandial, glycemic variability, be able to talk about it with CGMs or the sugar diaries if they're accurate. Everybody forgets about quality of life. Quality of life is so important. Sleep, sexual function, whether it's males or females. Mental health. This year, the NCD Alliance accepted mental health as one of the NCDs. We talk about equity, and yet equity doesn't exist. We are the ones who hold, we are accountable for equity for our patients, okay? We are very blessed in Kenya. We have generic medications available. So we can give equity to our patients. We are the ones who write the prescriptions. We have all the guidelines, but the guidelines are not carved in stone. So for every patient, deciding which way we are tracking down the guideline will really depend on the patient phenotype and characteristics. Like I said, not one size will fit every patient. And that's why you need to be ready as a tailor to change, to adjust, to pull out the stitches, to make new coats if necessary. Because pharmacotherapy will keep changing. And we're not just looking at glycemic targets, we're looking at the lipids, we're looking at the weight, we're looking at the mental health, which can't be measured by any lab test. So dynamic. Precision medicine is very dynamic. It involves honest communication. Put all your cards on the table. Okay. So it's very personalized profile prevention. And the ADA set up Precision Medicine in Diabetes Task Force. I don't know if you're aware about this. And this has really helped in prevention and utopian management of diabetes. There are organ specific considerations when you're deciding on what medication to start your patients on. So if, for example, there is fatty liver, thiazolidinediones do better, and the GLP-1 receptor agonists do better. If there's coronary artery disease, then again the GLP-1 receptor agonists and the SGLT inhibitors do better. Chronic kidney disease, depending on the EGFR, SGLT2 inhibitors. So depending on organ specific considerations, you write your prescription. Older age or frailty, when you're worried about hypos, DPP4 inhibitors. Obesity, bariatric surgery or GLP-1 receptor agonists, SGLT2 inhibitors. Poor compliance, they are once weekly GLP-1 receptor agonists. Other extra glycemic considerations, insulin, the high HbA1c, again, other medications. This list is not even exhaustive. If you're worried about hypoglycemia, again, the DPP4 inhibitors, SGLT2 inhibitors, GLP-1 receptors. So in precision diabetology, factor in everything as you write your prescription. Like I said, there is sub-classification of diabetes based on clustering. There is type 1 diabetes, LADA. There are subtypes as well. And there is different classification depending on what tools you have available. There is preventive care, population health. There is precision diagnostics as well. We don't have all the genetic studies available here, but we can refer. There are novel subtypes of type 2 diabetes. This is borrowed from my colleagues from India. They did a study in which they subtyped over 19,000 patients, and they used different variables relying on BMI, waist circumference, triglycerides, HbA1c, HDL, and C-peptide, and they had clusters with severe insulin deficient, insulin resistant, obese, combined insulin resistant and deficient diabetes, and mild age related. But we've had studies also from John Claude on our a subtype of diabetes where there is ketoacidosis, ketosis prone. So there are different ways of classifying the different subtypes. This is just the study I'm talking about. But the time is right for a new classification system for diabetes and implications. So again, sometimes people are missed when they are presenting as in between type 1 and type 2 with LADA. So we have to be very sure what we are treating, because sometimes people are not getting insulin when they need it. Other times people are being deprived of insulin when they need it. Like I said, this is a Herculean topic, so I'm just literally at the tip of the iceberg with what I'm showing. Monogenic diabetes, I won't even have time to talk about it, but many times MODY is being missed in our patients. So please think about it when somebody is not fitting in. It's misdiagnosed because of the overlapping phenotypes. So if you have a younger patient who is not responding, think about MODI. I'm not going to be able to show you that type 2 diabetes is mainly polygenic, and that's why there's clustering. And type 2, between type 1 and type 2, when prevention comes in with type 2, because of the clustering, we can prevent it, and it's lifestyle modified. The AD has come up with a whole algorithm you can follow to see if you're at risk for type 2 diabetes. And again, there are ethnic variations. I borrowed this from my colleagues in India, the Indian diabetes risk score, and the higher your risk score, the worse off you're doing. I'm happy for people to borrow my slides here with the organizers, okay, because I'm having to rush through. Again, when it comes to treatment, monitoring HbA1c might not be the best way. Type 2 diabetes is polygenic. Precision medicine in monogenic has been the most useful, but even in subtypes and clusters of type 2 diabetes, it's been useful. And like I said, we pick the medication depending on the subtype that we have. We know about the Agarese 11 type 2 diabetes pathophysiology. So we pick our medication according to which part of the pathophysiology, and that's why we use combination therapy. But the best combination we pick will depend on what we think the subtype of type 2 diabetes our patient has, or their phenotype, whether they're obese. We have people like in Southeast Asians, the lean fat diabetic or the fat thin diabetic person who has more visceral fat. We have people who are slim, like in sub-Saharan Africa, we have lean people, like I said, who are ketosis prone. In the West, we have people who are obese, they have a BMI of over 45 and they get diabetes at a later age. So we have different ethnic variations which we need to consider. There is a cluster-based approach. This is the one I'm talking about, where we have different fat deposition and then different medications work according to how the BMI of the patient is and how the visceral and peripheral and adipose fat is being deposited. Like I said, this is a huge topic, so maybe you'll borrow the slides. So the effects of drugs can also be tailored and directed towards the beneficial results. We know the SGLT2 inhibitors have positive pleiotropic effects, as do the GLP-1 inhibitors, and we choose appropriate therapy also based on cardiovascular and renal comorbidities. This is a really helpful, the RSSDI have come up with a risk calculator. So if you put in somebody's BMI, you put in their renal function, you put in their cardiac, it actually helps you come up with what is the best medical combination. So if we can come up with one for our ethnic, because this is based on an ethnicity based in India, I'm putting it out to maybe the KDSG to come up with something for Africa with our renal, our lipid profile, our BMI. It would really be great to come up with a Kenyan one because for our type 2 patients. So like diabetes phenotype is markedly different across ethnic groups. We need to take that into consideration as well. And drug outcomes will differ, and the ethnicities, Africa has really not been studied in a lot of the trials, and we're really making noise that we should be involved. But until we are not involved, we should do our own trials, and I really applaud KDSG for starting off on a lot of these trials. So that's really good. Like, for example, the DPP4 response is greater in Asian than in white people. So we need to see how our patients here locally are responding to certain groups of medications. And glycemic response to metformin has also been reported to differ by ethnic group. Again, prognostics, their complication risk is different in different groups as well, and different phenotypes of type 2 diabetes. So we need to classify phenotype and then see how our patients are responding. We need to also reduce the stigma. People come to me to see me and say, oh, I have mild diabetes, I have a lifestyle condition, and they don't want to take any medication because somebody's already programmed them that they don't need any medication because they have mild or type 2 diabetes. This cluster is one of the clusters I was talking about. There are so many different clusterings of type 2 diabetes. I'm finishing. This is something the nutritionist like Betty will be very excited about. Nutrition and genetics in type 2 diabetes. People talk about berberine and everything. So there are phenotypes who respond differently to different nutrition. This is a future direction in phenotyping and genomics, and this is a plan that the AD and EST have made. So we are still in phase 3. Phase 4 is really exciting to watch out for, because we will have different results and we'll have really huge benefits if we just practice precision medicine. So my take home message is that precision diabetes medicine has become a reality and we have to apply it, and the future is bright because it's an art and science. So the good physician treats the disease, but the great physician treats the patient who has the disease. Thank you very much.
Another round of applause for Dr. Acharya. Now, I want to thank Dr. Rilwan and her team for the theme, because we are all supposed to connect with each other as physicians, endocrinologists, cardiologists, nephrologists. We're all supposed to connect. So the next session is looking at heart failure, chronic kidney disease, and type 2 diabetes. The moderator will be Dr. Anne Wairago, the village doctor. We'd also like to welcome Professor Ahmed Sakwala, who's a nephrologist at the MP Shah Hospital, Dr. Rilwan Adan, the head of the Lions Diabetic Center, and Dr. Bernard Samir, a cardiologist. Please welcome.
Good afternoon. We are still dealing with the connections, keeping with the theme of this symposium, the power of connection, people, practice, and progress in diabetes. I have 3 panelists. One is Dr. Bernard Samir, who is a cardiologist at MP Shah. I have Professor Sakwala Ahmed, nephrologist from Aga Khan, and Dr. Rilwan Aden, who works in this hospital of Lions, and she's a diabetologist. I'm a villager, so we are still connecting from the town people to the village. This is still power of connection by choosing a villager to moderate the urban people, the urban doctor. This is a sponsored talk by the Boehringer. We have one patient, but has 3 different diseases, but the patient is one. And that's why the 3 specialists are here to talk about, at the end of the day, who is going to own this patient. The initial diagnosis was type 2 diabetes. And sometimes we label our patients wrongly. We say this is a patient, a diabetic patient. I see a lot in the word wrong. These are diabetic patients. So even the language we used to refer to a patient need to change. These are patients with, you have talked about the precision medicine. We need to clarify which type of diabetes our patient is having. We say this patient has type 2, has been living with type 2 diabetes. So there's this intersection of the 3 chronic diseases, the type 2 diabetes, CKD, and the heart failure. So I'm going to do a case presentation. There's one JO who, of course, this may not come from my village because our names don't start with O. There's a lot of W's and M, so this is not a patient from my village. Then you're going to see how the 3 organs, the pancreas, the kidney, and the heart are going to communicate to each other. Our patient is 58 years old, male accountant who is living a sedentary lifestyle, has been having type 2 diabetes for the last 10 years, present with worsening glycemic control, has hypertension, dyslipidemia, had an MI 2 years prior. The presenting complaints were shortness of breath on exertion, ankle swelling, fatigue and orthopnea, and nocturia. The question is, where do we start? You can see there's the diabetes. With the swelling, there could be the swelling because of the heart failure. Again, the kidneys could also be involved. Where do we start? The current medication for this patient as follows. We have metformin, gliclazide, losartan, amlodipine, atorvastatin, and aspirin. In view of the two last drugs is because of the previous MI. Putting numbers to this story of JO, we did some blood tests, and these are the figures. The HbA1c is above 7, so the patient had poor glycemic control. The patient has, the kidneys have compromise with the GFR of 44, which gives a stage of 3B. Then the patient has macroalbuminemia. EF is at 40, and the pro-BNP was high at 1,250. So you've seen this is a very classic cardio-renal metabolic triad. So how do we entangle it? So this is the time I'm inviting my three specialists, and I'll start with the diabetologist, because this patient, I think that when the diabetes here in this case could be the one which initiated, but if we are also finding some cases where the patient was initially just had heart failure and they developed diabetes, or had CKD and now developed diabetes. So now in this particular case that you're discussing, diabetes happened to be the first to come in. So let's hear from our specialists. What do you mean by good glycemic control in 2025?
Thank you very much, Anne. It just shows how people from the village can also come and manage this with us. So basically, before we come to 2025 and how we manage these patients with complex cases, we have the UK PDS study, which was done from 1977. It was a longitudinal prospective study. And we had the intervention arm and we had the non-intervention arm, where they were looking at patients on lifestyle and all that, and then the patients on insulin and the sulfonylureas. And they showed that just focusing on the sugar, of controlling the sugar of the patient and looking at only the diabetes, showed that these patients' complications were reduced. And the major complication being reduced there was actually the microvascular complications. As you can see, they're at almost 25%. But we do not have a significant improvement in the macrovascular complications. And we know that patients with type 2 diabetes, even apart from JO, who's had type 2 diabetes for 10 years, we have even in early type 2 diabetes, early in diagnosis, you have an increased risk of complications. They can present with that CKD at presentation, or even the heart failure at initial presentations. And we have the increased complications because of these other risk factors, which are not only the metabolic aspect, which is the diabetes, but you have the hypertension, you have the dyslipidemia, you have the smoking that happens in these patients, of course, with the background of insulin resistance and hyperglycemia from the diabetes. And with all that, you have the macrovascular complications, which we all know is the leading cause of premature death in our patients. If you look there, you have patients with no diabetes. If you look at the life expectancy there, it's reduced when they have type 2 diabetes, even further reduced with the CKD, and even more reduced if they have the cardiovascular aspect, the MIs and the heart failure coming in, with up to between 5 to 12 years reduction in life expectancy. So what are we looking for for these patients? Early on, as the diabetologist, we're looking to minimize the risk of these complications. They may not present to you with these complications initially, but our focus is to minimize the risk of development of these complications, both the cardiovascular and the renal complications for these patients. And so we look at Dr. Acharya mentioned the patient-centered precision medicine. Look at the patients, look at the characteristics of your patients. Just don't look at the sugar, because you're the diabetologist, endocrinologist, and then you leave the rest for Sokwala and Samia. So we look at them as a whole, and we look at them with a multifactorial approach to be able to prevent these complications from coming in. And so with this multifactorial risk management, our patients would benefit by controlling their HbA1c, controlling their weight, controlling their high blood pressure, controlling their lipids. And what better perfect armamentarium of medication that we have than the SGLT2 inhibitors, which have demonstrated in various studies that it can do all this for us. And not only slowing the progression, but also preventing the development of these complications.
Thank you, Dr. Rilwan, for taking us through that. So let's move from the pancreas and I'll move to the heart. I think the heart is, I think we leave always the kidney the last, and I know Dr. Sakala will not be happy with that, but I think the heart, matters of the heart comes first before the kidneys, yeah? So I'll skip here and I go to Dr. Samia, who is going to tell us how can we detect heart failure in this patient before the patient is hospitalized.
Thanks so much, Dr. I'm the village doctor. Always a pleasure to meet people from the village. And my colleagues for sharing the podium here. So it's an interesting thing. What the heart wants, you give it, and is usually happy with you. So this is a case where we've seen a patient who is type 2 diabetes for quite a long period of time, 10 years, has additional complications, chronic kidney disease, has been diagnosed with heart failure, reduced ejection fraction, and is presenting with symptoms, shortness of breath and fluid overload. And the entry of this complex patient into clinical care would really vary. This patient could pitch fast with the endocrinologist or the diabetologist, the nephrologist or cardiologist. So I think in the spirit of connectivity, you do your part and always refer to your colleague and see what they can do. So as far as heart failure is concerned, for example, the patient we have, what has been shown is patients with heart failure who additionally have diabetes have worse outcomes in terms of clinical events compared to those who have heart failure without diabetes. And this would include things of, just before that, please. Increased risk of death and hospitalization. There's some figures, probably more than 50% higher hospitalizations and so on. And patients with diabetes who get heart failure could have the phenotypes of heart failure, reduced ejection fraction, heart failure, preserved or mildly reduced ejection fraction. And they sometimes can cross in between, especially those who are on treatment, improve the ejection fraction, or those who fare badly can go down on ejection fraction. And again, it doesn't matter whatever the phenotype of heart failure one is dealing with. It's been shown that the cardiovascular death and hospitalization events or rates are worse with the patients who have diabetes. So if you look at this very old study, 2008, which was comparing event rates in patients with the two phenotypes of heart failure, whether they have diabetes or not. And clearly what we see here, it doesn't matter what phenotype it is. Some of these information slide might be misleading. To date, we do know that the outcomes of heart failure with preserved ejection fraction is just as bad as that of reduced ejection fraction. I think these were studies done at a time where people thought the preserved ejection fraction was a fairly mild disease compared to reduced ejection fraction, but that seemed not to be the case anymore. So I just wanted to highlight a little bit what exactly happens to a patient who has diabetes as far as the cardiovascular system is concerned. You can have disease happening in many prongs, but three clear ones that are demonstrated here through coronary artery disease, where there's the typical atherosclerosis, multivessel commonly involvement, and these are patients sometimes come to cath lab, they're given stents, and the rate of restenosis is extremely high. There are many areas of disease and very complex disease. On the other hand, you can have patients who do not have coronary artery disease, but they have reduced heart function, and this is an entity called diabetic cardiomyopathy, and through various mechanisms, toxicity of glucose and through other many pathways. And this can manifest either with reduced or preserved ejection fraction. Then you can have the autonomic neuropathy, where again, you have just some abnormal sympathetic denervation and so on. Patients, for example, have hypotension, reduced exercise tolerance, and so on. So back to the patient where we were looking at, how do we detect heart failure in a patient who has diabetes and multi-organ chronic kidney disease? Index of suspicion is high, I mean, there's every chance that a patient who has diabetes, especially long periods of diabetes, is going to have some form of cardiac abnormality. So simple tests starting with an ECG, there'll be some abnormality that can be detected. If we are going to do cardiac biomarkers, commonly we have pro-BNP or NT-proBNP, they would be abnormal. Then an echocardiogram is very important. Our patient has a reduced ejection fraction, which is easy to pick, but there are those patients who have a normal ejection fraction. Then we have additional entities, what is called diastolic dysfunction, which could clearly be demonstrated. We have more advanced tests to detect cardiac abnormality in such a patient, but I think for a start at a basic level setting, echocardiography is important. I also wanted to mention that patients with heart failure, diabetes commonly would have chronic kidney disease, either because of the progression of the disease, and it's really important when you are selecting the kind of medicines we want to use for these patients, because there's a lot of positive interrelation of the medicines and negative interrelation. Can't use medicine 1, 2, 3 because they have underlying kidney disease. And finally here, just as we are selecting medicines to manage our patients with the hyperglycemia, I think from the diabetes colleagues, not just the glycemic control, but we are also looking at, do they have background heart failure? Do they have background atherosclerotic cardiovascular disease? And key medicines that are really going to be important in selecting, especially those who are at high risk already or already having heart failure. SGLT2 inhibitors are really important. And those who have atherosclerotic disease, the GLPs are important. I think my colleague here is going to talk about the role of non-steroidal MRA, because we've also shown, it's been shown in studies to be really important, especially for the mildly reduced and preserved ejection fraction. Especially this was in patients with the obesity, but the same extends even to the diabetes population. So can we be able to prevent development of heart failure in patients with diabetes? These are key simple things. You optimize management of the coexisting comorbidities and risk factors, for example, blood pressure, lipid, weight, and so on. You do routine examination of this patient with ECG and echocardiography. You check for urine. You optimize lifestyle, and the key role of RAS inhibitors in prevention of progression of kidney onset or progression of heart failure. Then, of course, the other two new medicines I've mentioned, the SGLT2s and GLP-1. Thanks.
Thank you, Dr. Samir. Clap for him. Let's move to the last organ, but not because it's not important, because the minute you don't go and pass that urine, you realize how important that organ is. So now, to Dr. Sokwala, when the kidney whispers, what do we do?
Thank you very much. And the final pathway is the kidney. If you've treated patients, that's when you start struggling, calling the nephrologist, even in the ICU. Now the kidneys have failed. Probably call them earlier before it's too late. So I like that alarm thing there as well. When kidneys start misbehaving, everyone gets a little more alarmed. But this alarm should start much, much earlier, before the kidney even starts getting affected. And why do we have this, diabetes, CKD, heart failure, high blood pressure? It's all because they have the same risk factors, right? So we need to prevent those risk factors so that we don't reach at this stage where now you're starting to manage the kidney, the heart. So prevention, number one, right? Then, obviously, which when we look at our patient, what do you want to prevent? Now he has reached that stage when you already have the diabetes. You want to prevent worsening of your heart failure, worsening of your renal function, prevent mortality, and reduce cardiovascular events, right? Those are the 4 things you want to do. And we'll see how we can do that as a team and a multidisciplinary approach. So one thing to pick up these patients early is urine albumin creatinine ratio, and it's a marker of endothelial dysfunction. All these patients, the reason they get all these strokes, MIs, etc., it starts from the endothelium, right? And if your endothelium gets affected, one of the good markers to look at is actually a urine albumin creatinine ratio. If your UACR is going up, your endothelium is getting affected, you're at a higher risk of getting an MI, you're at high risk of getting a stroke, high risk of heart failure. And that's a heat map chart. All of us have seen that before, so I won't really, no, go back. So yes, so, if you can see the green areas, okay, when you have that patient there, start acting at that time so that you don't reach the orange and the red areas, right? And if you've reached the orange and the red areas, refer these patients early to the nephrologist so that, don't think that, okay, I've been to this lecture, I've heard that, I'll start these guys on these treatments. But there's some other things the nephrologist thinks about, and it's a multidisciplinary approach that probably you might not have thought, and they'll add something to it. Next slide. So that's the natural history of diabetic nephropathy. As we all know from our physiology, starts with hyperfiltration, and then gradually, the GFR going down, and those are the GFR on the y-axis and the number of years of diabetes on the x-axis. The microalbuminuria starts little, gradually as your endothelium is getting affected, gets albumin creatinine. So people have looked at, and maybe I forgot to mention that, the higher the USCR, they looked at the carotid intimal plaques. The number of carotid intimal plaques increases as your USCR increase. Next slide. So, a patient with proteinuria, diabetic, something you shouldn't forget about is it could be something else. Not only diabetes would give you proteinuria. 50%, this is a study I've put up there. They look at diabetics and they biopsied all the diabetics and look at which patients had diabetic kidney disease and non-diabetic kidney disease. And if you look at that chart there, almost 50% of patients did not have diabetic kidney disease. So don't assume a patient has diabetes, has proteinuria, always has diabetic nephropathy. Look at other things. And we've had in our own cases, and I'm sure you guys have seen it as well, you get other things which cause proteinuria, treat that proteinuria, and your kidney improves, and your proteinuria improves. I see a lot of light chain nephropathy, anyone above 50 with diabetes, proteinuria, I at least screen them for, multiple myeloma, etc. And feel, you've not biopsied enough if you don't get diabetic nephropathy in your biopsy. So send these patients to nephrologists and encourage them to biopsy these patients. You can get from IgA nephropathy to lupus. I've seen all kinds of things in diabetics. So then we said we want to reduce the 4 risk factors: mortality, hospitalization, cardiovascular events, and I don't remember the 4th one. Anyway, so we have different armamentariums to improve the function and the endothelial function of these patients. And one of the things we've seen is the hyperfiltration. That's where we start. So how do we reduce hyperfiltration? How do we reduce the interglomerular pressures in these patients? We had started with the RAS inhibition initially, and now we have the SGLT2 inhibitors, and that's literally reducing interglomerular pressures. And that's a diagram to see the physiology of how that works. And I won't dwell into much into that. Maybe a little bit. So RAS inhibition, just go back, increases your efferent arteriole. So your interglomerular pressure decreases, you decrease the hyperfiltration, and it's proven renal protection in many other studies like IRMA, etc. The SGLT2 causes, again, reduced interglomerular pressures, and you can use them both concurrently so that there's much reduced interglomerular pressure, you reduce proteinuria, and then your outcomes, cardiovascular outcomes are better. Next slide. And this is, shown in many studies. We've all seen these studies before. Credence, DAPA-CKD, EMPA-Kidney. These are the SGLT2 trials. And, the latest one, the EMPA-Kidney, has gone into a less and less GFR, where they use patients with even GFR of less than 20. More than 50% of their patients were non-diabetic. So SGLT2 can be used in diabetics and non-diabetic patients. And what they looked at is actually what we were saying, those 3 or 4 things we want to prevent our patients. JO, was it his name? Yes. So again, if you start these patients on these drugs early, you prevent them to reach end-stage renal disease, and that's one of the things we want them to do. The earlier you start your SGLT2 inhibitors, the more you prevent them to go into dialysis, the more you prevent them, the years they'll reach into end-stage renal disease. Next slide. So let's take an example. If you give a patient empagliflozin when their GFR is around 80, 85 versus placebo, you buy them at least 26 years of dialysis, okay, of your eGFR going down to 10. But you can start it even later. If you start them at 20, then you buy them at least 2 years. So these are some of the drugs you can use to prevent progression and reaching renal replacement therapy. Another slide, next slide. Similar scenarios, and the number of dialysis sessions you potentially avoid if you start these drugs early. Next slide. That's a summary of the SGLT2, and you have to make sure patients, especially with kidney disease, slight acute drop in the GFR, but there's long-term benefit. And if the GFR drops more than 30%, then you have to be careful. These patients, we said they have heart failure as well. You start them on SGLT2, they are on diuretics, adjust your diuretics accordingly if they get volume depleted. Next slide. So the other drugs, again, looking at patients with heart failure, CKD, and diabetes, like finerenone, multiple trials. We won't dwell a lot because we don't have time. The Figaro DKD trial looked at whether finerenone improves cardiovascular outcomes in type 2 diabetes and CKD, and yes, it does. There was a reduction of almost 12% in the primary outcome and around 10% in the secondary outcomes. And those are the outcomes we're looking at for our patient, right? Reduced cardiovascular death, MI, or hospitalization. Next slide. Then slowing of CKD progression. Again, it has shown to slow CKD progression almost by, if you're using finerenone, almost by 17% reduction in reaching end-stage renal disease. Next slide. Then a combination of both trials, and that's what they showed. Next slide. Again, the newer trial, the FLOW trial, using the semaglutide for CKD patients in type 2 diabetes. Again, that is another armamentarium we have to use in this kind of patients. Next slide. So I think we have a good way, starting from prevention, early detection, appropriate therapy, to help this patient of ours to live longer, stay out of the hospital, and avoid cardiovascular outcomes.
Thank you, the team. Let's clap for him again. Now you've seen you move from the diabetes to the heart to the kidney, and this is the same patient. So these are vicious cycle. The diabetes made this patient have the heart failure. The heart failure again worsens causes the kidney for dysfunction. The diabetes again can cause this kidney dysfunction. So there's a vicious cycle happening to this patient. But as you said, Dr. Sokwala says not every CKD in a patient's diabetes is, some of them are non-diabetic. So there's sometimes you need to do a kidney biopsy to identify the non-diabetic kidney failures. So, but is there a way that you can differentiate clinically the non-DKD and DKD?
So good question. Very difficult. Okay, very difficult. There's some things you can look at, retinopathy, etc. If a patient has other microvascular disease, then you think this is most likely diabetic nephropathy. But you can still have retinopathy and you can still have IgA nephropathy, right? So it's difficult. So a couple of things you look at, like if a patient had a proteinuria before and you have a sudden rise in proteinuria, then obviously biopsy that patient. Sudden rise in creatinine, think about other things. Those are some of the things you can look at to help you decide whether this patient needs a biopsy.
So, Dr. Ridwan, who owns this patient? Is it your patient, or how do you, the three of you?
We'll give it to the diabetes.
Yeah, Ahmed knows he's the dialyzer at the end of the day. So basically, we all own these patients. It's a multidisciplinary approach, and we all have to co-manage these patients. Obviously, initially, we need to look at from where I'm sitting, I need to stratify this patient, put them on the medications they need early. I'll go back to Dr. Acharya's talk, and that's why we felt we had to put precision medicine in the program, because we need to look at our patients individually, and we need to look at them in such a way that what do they need? So from there, obviously now they take over. depending on the comorbidities that come in.
So there's the connection. The three team have to connect. They're where sometimes where we work, the physician is, I'm the three in one. I'm the cardiologist and I'm the nephrologist. So for me now, it's easy to change from a cardiologist. When it comes to cardiologists, I have some of my registrars around here. My MO is here. So they know we deal with all the cases here. So now the take-home message for those one who, for the interest of time, I could have continued the discussion. But this is for the sake of that clinical officer who is working in Embu. There's somebody from Embu here. What do you take home? So once you see a patient who has diabetes, please screen early, especially for we may start with the urinaries, we may find a VAT proteinuria, but doing the urine albumin creatinine ratio, the microalbuminuria helps. Then again, calculating the GFR, we have already calculators which you can use and determine what the GFR for this patient. Assess for early heart failure symptoms and refer accordingly, do those ECG and echoes. Prioritize, there's some low-lying fruits like monitoring the blood pressure and controlling it, making sure the lipids are within the target. Then when you're choosing, you've heard all of them have agreed. There's a drug that everybody has talked about, the SGLT2 inhibitors. SGLT2 inhibitors, I think initially it was supposed to be the diabetologists, but now later it was found that it has more pleiotropic effects, that it's not just for glucose lowering properties, but also cardioprotection. As you can see, the different CVOT trials have shown that SGLT2 inhibitors have a role. And again, when it comes to the renal, they have renal protection from the different renal studies. They've shown their quite protection. So a patient who has the three of them, and you're not put them on SGLT2 inhibitor, then you're doing disservice to that patient. Finerenone is mostly, especially in the background of CKD, but the cardiologists have said this, so they're also finding it has also its use as an nonsteroidal mineralocorticoid antagonist. So you need to collaborate, the collaboration, the connection between the team. So we need to also early referral to the specialist. So beyond the pages, we need to move towards connection in care. Think about connection, not compartments. Treat early the three conditions. Act together as a team or refer when you don't have the whole team together. Protect one organ, but at the end of the day, you're protecting all and you're preserving the three. So the future, I'll leave you with this quote, that the future of diabetes lies in teamwork, that is connections, because the body doesn't know the specialties. Thank you.
Thank you. So just one, it triggered me when Luan said that Dr. Sokola is a dialyzer. So I'll give you a case I had just 2 weeks ago. The patient was sent to me for dialysis. Creatinine was 400. And the patient had seen a cardiologist, had lower limb edema. That's why he was referred to the cardiologist. And then they were giving diuretics. The creatines were going up. The diabetologist was managing. And the gastro now was seeing for some GI issues. And the patient ended up to me for dialysis. And when you look at the patient, he had massive proteinuria, right? And that was and his albumin was low, and that was the reason why he had swelling in the lower limbs. Okay, he had diastolic failure. That's fine. So we biopsied this guy, had FSGS, give him treatment. He's off dialysis. His creatine's 100. Thank you. So I'm not a dialyzer.
So I'd like to call again Dr. Ilwan and Dr. Gaman Mohammed. Now, most of you know Dr. Gaman Mohammed with regards to CGMs. If any of you have not attended his talks or have not sat down for CGM training, I would really, really encourage you to. It's very educative, and especially where patients are now asking for them. Thank you. Please welcome.
I'm sure most of you are seeing Dr. Abdullahi on the program. Dr. Abdullahi could not be here due to unavoidable circumstances last minute, so I'm just sitting in for him. So disclaimer, the slides are not mine, and I'm just sitting in.
Nice excuse, Rilwan. You're in it. You have to sit in it. So anyway, I'd like to thank the organizers for inviting us here today. So really, we're supposed to sit, talk, discuss, try and maybe understand what's happening. So what we're going to do today is maybe talk about what's really bothering us first, which is how do we improve our knowledge and skills and use CGMs locally? Because we know it's here to stay. How many of you think that CGMs are here to stay and are critical? So that's about 95%, except Zaira. She was on the phone. Anyway, so that's what we're doing today. So just for those of you who maybe were not there in the year 2000, I think there are some people. This is our evolution of really technology development in Kenya. So we're going to start first with here. 2002 is when we first used our CGM. Our first paper was in 2003, I think, at the IDF Africa. And over time, we've had pumps with automatic shutdown. We used our DIY artificial pancreas in about 2017, and now we're using the hybrid closed-loop systems or the automated systems. But really, Rilwan, CGMs are really, I think, going to change, and we know it's critical for type 1 diabetes and also type 2 diabetes. It's really critical. But we have challenges: cost, accuracy, access, literacy. But I must mention that Kenya is one of the leading uptakers of the IDF training, CGM training models. If you look at Kenya, both in terms of patients and healthcare professionals, we are probably third in the world in terms of training. The uptakes online training from the IDF modules, sorry. So that's quite impressive. So the need is there, but cost accuracy remains the problem. So Rilwan, what do you think? What do you think is going on? What do you think we need to look at?
Yeah, I agree. I think just going back to your point on Kenya being an uptick, not just with CGM, I think in terms of the whole armamentarium of even diabetes therapy, we are just top notch. And if we look at, we sit in meetings with our colleagues around, we're actually very good at that. And I think when we come back to the CGM, what we need to look at is, because we're going to have more of this around, there are more of it around. What we have there is, you can see the CE mark there, which is from the European markets, and we have the FDA there. So you'll have a lot of the market flooding with a lot of CGMs. The CE mark there, when you look, you say, oh, it's Europe, so it's being used in Europe and it's okay. It's just a marketing authorization per se. It does not focus on the studies that were done using that CGM. It does not, the accuracy is not the focus for them. Probably the safety is, yes, but the accuracy is not. As opposed to FDA, which look at the studies which were used in the CGM studies. They look at the accuracy factor, they look at the patient population and all that. So I think let's just not rush and look at the marks, but also look whether the studies have been considered. Because if you look at it, these are your blood sugar. It's a matter of life and death when you look at the sugar levels in terms of hypoglycemia and all that. So if it's not accurate, we should not be really jumping to it and being comfortable to using it. Yeah, Gaman?
Yeah, I think that's important. So CE marks just tells you they have tested it based on the information that they were given. It says in their study of 20 people, but it doesn't really look at rigorous testing of the CGM. So if I have 40 patients or 35, and I say, yeah, I had a MAD of 10%, I can get CE regulation. Yes, what I'm saying is true from what I presented, but it's not rigorous market testing. So do you want to tell us a little bit about this? Is it a monster or is it what is MAD?
Yeah. So basically, that's what we look at. Whenever we get the CGM, that's what we focus on, the MAD. And like Dr. Gaman said, if we see the MAD is less than 10%, we are comfortable. But how do we get to this MAD? Like he just said, we just don't focus on it because MAD is complex. As you can see there, it's the mean absolute relative difference. So it looks at your high sugars, your low sugars, and this is like putting your CGM on a roller coaster. Up there when the sugars are high, come down suddenly and move up quickly. So when you put this CGM on a roller coaster, what is the outcome? And that's the MAD, yeah? So the higher the relative difference, it's not as accurate. So the lower the percentage you get, the better the CGM. If you get 8%, a lot of them are, I think 8% reporting, it's good enough. But now the complexity of getting the MAD is where the catch is. You need to look at the studies again that were used in that CGM because there are many factors that affect this MAD. So if you just give it to a patient who does not have diabetes and you calculate the MAD using that, that would be very good because this patient does not have the variability of the sugars in terms of highs and lows and all that. And study population, quite important. Our type 1 patients or our type 2 patients who are insulin dependent have to be in these studies because if you have not looked at it at the various, the variability of the sugar is not a factor in it, it's not quite effective. You need to look at the site of the sensor wear. How long has the sensor been worn? You need to look at the meal and the insulin challenges, and that's what we talk about, our type 1 patients who have the insulin injections multiple times a day.
So if I was to explain this a little bit further, we all want to buy a car. We all want to buy a car. We all want to buy a car. So if you want to buy a car, we give you two options. I'm there and I say, yeah, this car has been tested on a flat road. The highway, it's got no problems. It's running at 80 kilometers on a flat road. But if you have someone that said, no, my car runs on a flat road, but also has been tested in windy roads, potholes, yeah? Which car, rough terrain, which car would you choose? The one that has gone through rough terrain, isn't it? The fact that it's going 80 kilometers on a flat road does not mean anything. It's how you tested the car that's more important. This is where the issue of what Rilwan was, the MAD context, where this accuracy you're saying, or so-called accuracy of, or MAD of less than 10%, what was the study behind it? Was it on a patient who has no diabetes, pre-diabetes, type 1 diabetes? So maybe Rilwan, you can take us through how we want people to take this forward.
Yeah. And as you can see on the screen there, Find has come up with a performance fact sheet, which can guide you. And there's a QR code there, which you can get to scan and get the fact sheet. And just looking at the fact sheet, you look at, it gives you the confidence to know that if I look at this CGM, you look at the study population. And with the study population, at least the type 1 population have to be in this study, which this CGM has been used. Because now that's where Dr. Gaman is talking about the rough terrain road, the pothole road, and the checks that you've been done. Because if you do it on a patient with prediabetes whose sugars are quite, the MAD would be looking very nice. But if you look at that challenge, if it has gone through that challenge, you'd know that the study population, the type 1s are the best, or the type 2 who are insulin dependent. And then you look at the number of people in the study. Obviously, sample size, always good for every study to look at. But again, your sample size can be probably 1,000 in that group. But what percentage of the type 1s are in that? So that you can be able to get a because you put 10 type 1s and then you put 1,000 pre-diabetes will not give you enough. The sensor wear time, especially the time that you want the sensor, because most of our sensors go for probably 10, 14 days or so. So at the beginning, towards the end, was the sensor wearing throughout, because you get probably the last 3-4 days of the sensor wear. In the middle, probably you might get a good there's not much variability. So if you have sensor wear, probably a study included that the sensor was worn for 3 days, 4 days, that might not give you some accurate data over there. And then of course the glucose data distribution, which we talked about, the highs and the lows. Do you have the population where you're having data which is very low, very high, or you're just having that patient who is having your sugars of 6, 7, 8, 9 and is in this platform, or you're having patients who are having sugars of 3, sugars of 17, 18. So the data points that have been included is very much quite important there. And then last but not least, obviously the type 1s and the meal and insulin challenges we get in these patients. So this will actually be able to give you the rates of the changes in the glucose level. Because when the patient eats, you get the spikes. When you put the insulin, when you give the insulin, you might get sugars dropping. So that rate of spikes and drops will actually give you the accuracy level that you're looking for. And then obviously the study publication. Was the study published in a peer-reviewed journal? Because if you just have studies just being put in any journal which is not being looked at critically or critically appraised, you might not be able to get that.
Yeah. So we have issues maybe with challenges with affordability, where we say we can't afford CGMs. So how can we make it happen when we are sure that this CGM is accurate? It's probably not affordable. So what can we do? So maybe we need to think through and say, should we use CGMs intermittently for certain patients? Should we say, okay, this is a patient with renal disease, type 1, pregnant. We want to have more of our CGMs or spend more of our funding on that sort of a patient. We need to expand the industry so that more people come in with their CGMs. They should say, yeah, let's test them. Let's do local studies on our CGMs. When we do local studies in our CGMs, yes, we can probably prove that some of them that we think may not be as accurate are perfectly accurate. Remember, you don't know until you test. So this is an important thing. How we interpret it, do we use AI tools to help us? Do we look at national programs? And I think we're having a meeting next week to try and subsidize some of this. Can Shah maybe come in and say, okay, we will subsidize this for that type 1 who was being admitted every month? Would a CGM save costs? Yeah. So can we train more, providers? Can we have VAT been, import duties been exempted? So all these are factors that we can look at. So I think we are running short of time. So should we skip this or should we?
I think registrar should do it.
Okay. So basically, what's coming in the next couple of months or years, and what's long-term care in terms of innovation, according to what I think. So what we have now is we are having improvement in our CGMs. We'll have a 1-year CGM coming up. We're having GLPs and insulins that we can use once a week, smart pens. And this was just registered, I think, 2 weeks ago. It's a non-invasive CGM, but it's for type 2s mainly. Over the next couple of years, we will have CGM scale-ups. We'll have screening for type 1 diabetes is going to be big, maybe not in our setup because of use of drugs that can actually delay diabetes for about 2 years. So, this is something that would be interesting. And in the next 3 to 10 years, we are looking at optical sensor where, optical tear sensors, beta cell therapies, where we encapsulate stem cells to avoid immune recognition. So all these are some of the things that are exciting and will come. But what about locally? Some of the things that we have looked at locally or are being done locally here. So let me just share this.
Can you just tell me what inspired you to develop this clock, or tell me a little bit about it and what inspired you to have this clock?
Definitely. So, Doc, the clock is basically a small little device that connects with your phone and your pump. So it's all integrated. It shows your blood sugar at the same time. It displays the reading as well as the arrows, the trends as you cycle through it. And what inspired me was just helping people ease their blood sugar management as well as, well, at night, not overlooking at your phone, not over getting blue light in your eyes, making sure you have a good night's sleep. So whenever you're asleep and you actually need to monitor your alerts, you have something very simple. You can get up, you can take a glance at your clock, your thought process is okay. You say that yes, my blood sugars are fine, or no, they're trending up or they're moving down. So you can move and take corrective action when you need to.
Okay. So like right now, it's showing us both on your phone, your pump, and the clock. You're at 6.9. What does the green line mean on the clock here?
So the green line is the indication with the sensor. So each area, at the moment there are four.
Yeah.
So after the fifth one comes on, it'll update with the sensor every 5 minutes.
Yeah.
But there's a slight lag based on the Wi-Fi connection.
Okay.
Although you always get pretty similar readings throughout.
Okay.
And it always gets updated and it's synced.
And the color green means what? You're in target?
Yes. Green is you're in target.
Yeah.
And you have preset values and preset colors that you can use.
Perfect.
So if it goes below target, let's even say you're prone to hypos and you put a target at 5 or 4.5,
Yeah.
it'll turn red.
Yeah.
And you can preset values for an alarm as well.
Okay.
So if it hits 5, 4.5, 4, the clock will beep. And it'll do the same thing with high blood sugars. You
Okay.
just preset it.
Good. So I'll leave you with the rest of the team to talk a little bit more about it.
Imagine starting your day without reaching for your phone. Just one glance at your bedside clock and you already know your blood sugar levels. It's simple, smart, and convenient. That's what our clock does. Consider easing your blood sugar management with a clock that connects to your pump or your sensor and displays the reading. The moment you wake up, you can glance at the clock and look at your readings. You can use the clock in the office to monitor your child's readings as well. This will help you stay focused in meetings as well as reduce screen time by quite a bit. The clock also has an alarm which rings when your blood sugar goes above or below a preset value. The clock also has multiple functions which shows your blood sugar readings with the time, as well as these additional functions shown below. Consider how this can help ease management, reduce phone screen time, and keep you focused at work, since you just need to glance at the clock to get the relevant information needed. With such a clock, blood sugar management becomes easier, smarter, and less distracting.
Can you just?
That's locally.
Yes. So next, let's look at wastage of insulin in automated insulin delivery system. So we have a patient of ours who we shared with the Aga Khan team as a child. She's now in Portugal, and as one of her dissertation, came up with a way of knowing how much insulin she needs for her pump. So basically, avoiding wastage of insulin in her pump. Like for example, here, can you see that there? Someone is changing their tubings. They have about 20 units of insulin that they're going to waste. So my estimate was about where a person loses from our data 50 to 60 units per week, which actually would cost about 20,000 a year or 200 to 300,000 shillings in 10 years. So this girl, her name is Filipa. You can listen to her and what she's saying.
Everyone, my name is Filipa and I'm a grade 12 student in Portugal, and I've been a type 1 diabetic since I was 6. And thank you so much, Dr. Gammon, for this opportunity. This all started with how I had to write a paper about anything I desired within my math class, a report that was personal to me and applied the math that we learned in class. And so being a diabetic that often has insulin waste involved when filling my reservoirs, I decided I wanted to optimize my insulin use and figure out what the optimal height and volume was for my reservoir. And so I did all of this using calculus. I first started off with converting how much one reservoir is into centimeters cubed to facilitate calculating the height afterwards. I took a picture of my reservoir and graphed it, and then using functions and so on, I found out a conversion factor for centimeters cubed. Online, it says that milliliters and centimeters cubed is usually the same, but I felt like for a degree of accuracy, I wanted to calculate it myself. Now that I had the total amount of centimeters cubed that a reservoir could fit, I wanted to find out how much I consumed daily or within the 3-day period that reservoirs are meant to be used. And so the whole point of this investigation was also by optimizing my reservoir, I can minimize skin infections while also the financial waste that comes with insulin waste. And so in the past, I used to fill in my reservoirs all the way up to 3 millimeters, and then they would be used for 6 days, and I would get rashes. And my doctor even just suggested just fill it a little bit less, see how that goes. But I would still have some waste involved. And so what I did to figure this out was I used Caroling to generate 5 reports of 90 days. And like this, I had data for 1 year of how much insulin I used every day, including bolus and basal specifically, as well as the tubing amount each time I filled my reservoir. So with this, I used just basic statistics, mean and mode, to calculate how much insulin I used per reservoir in units, which was around 169. And then using my conversion factor, I put this into centimeters cubed. At this point, I had already found my optimal volume, but in reality, when I fill a reservoir, I'm not really thinking about the centimeters cubed. I'm thinking about the height and which line in the reservoir this corresponds to. So I used the volume equation of a cylinder because the reservoir can be approximated to that, as well as a variety of differentiation rules like this differentiation and related rates to also compare how the volume decreases and the height decreases with time. And my ultimate result was that I, every 3 days, consume around 1.6 centimeters in height of insulin. And on my reservoir, this corresponded to just above the 2 millimeter mark. And I have in fact been trying this out, and it has been working pretty well. So in reality, now my insulin waste is so much lower than before. This was very helpful for me, but it also applies to so many other people in the world that are suffering from financial burdens that come with diabetes. Personally, in Portugal, the government pays for my insulin, so I don't worry as much about the financial burden that comes with insulin waste. However, in countries like in the United States, where insulin prices are extremely high, this is very impactful towards families because not only do they have to pay the insulin that they need out of pocket, but also are still paying for what they do.
So basically, what she did was she used a mathematical model to calculate how much insulin she'll need in a cylinder because she realized the amounts were not the same. So saving some insulin, uh, loading your reservoir based on what you require and not wasting, as I was showing you earlier on in the earlier slides. Okay, so I think this is what she was saving because she actually uses the exact amount of insulin that she needs based on mathematical modules. Good. So I think because of time, that would bring me to the end of our talk. We can have a few questions maybe, and then close.
Any question? Just one question, please.
Thank you for an excellent presentation. My question is about a group of people that we encounter in our practice. There may not be as many. Recently, I was involved in a discussion about pilots and if they can go back to flying if they have an insulin pump and a CGM for management of their diabetes. So the question was, would you trust a pilot to use a CGM with the logistics that are involved? I'm glad to hear that you can just glance at a clock or a receiver and know your blood glucose at the moment. And then the other thing is, how far can that receiver be at? If someone is flying, for example, from Nairobi to New York, would the primary caregiver on the ground be able to know all is well? And this group of people also work for the Kenya Defence Force. So it was quite a sensitive matter. Thank you.
Okay, I take that first. Okay, quick one. There is a South African Airways pilot who's flying, and this is commercial, with an AID system. So if it's a battle you can win, because with AID systems, hypoglycemias are almost impossible. Okay, all right, and we can set targets for them to run the sugars a little bit higher, so that is possible. Okay, for the clock system or any basically alerts for someone who's away from the care person, as long as there's Wi-Fi. If there's Wi-Fi on the plane, you can be able to follow them up from anywhere. Yeah.
Due to time constraints, we'll ask for all the presenters to come up. For question and answers, we'll ask you to go to them personally over the lunch break and ask them the questions. So I'd like all the presenters, Dr. Kirti, Dr. Samir, Professor Ahmed, to come up. So, Dr. Samir, thank you so much. Dr. Kirti, thank you so much, ma'am. Dr. Gaman, as always, thank you so much. Prof. Ahmed, thank you so much. No, gentlemen first. Um, Now, before we break for lunch, I would like us to give our platinum sponsors a minute. So any representative from Boringa, please try and be brief and sweet. After Boringa, we'll have Ethica.
Ladies and gentlemen, doctors and fellow colleagues, good afternoon. Yes, it's afternoon. Good afternoon. My name is Anne Kongo. I am a medical representative from Boringa Engelheim, now under DP World, and I've been given just 1 minute. I had a speech, so I'll cut it short. Boringa Engelheim is involved in pharmaceuticals, and for the purpose of this symposium today, our focus is mostly on cardiorenal metabolism, that is diabetes and hypertension. And whereas we have a stand just outside here where we will also interact after the session, I'd like to give a small analogy why Boringa does what we do. And I'll use Dr. Gaman's analogy of the car that goes, that drives on a straight road and the one on the rough road, okay? So for Boringa, we ensure that because our relationship as farmer and doctors is very symbiotic. And the goal is one at the end of the day, for our patients to get better and for their quality of life to be improved. So that is what Boringa Engelheim does. We have our hypertension portfolio, which is telmisartan. And then we also have our diabetes portfolio, where we have an SGLT2 inhibitor, empagliflozin, Jardiance, and also we have a DPP4 inhibitor, a novel innovation, which is linagliptin, Trajenta as the brand name. So Boehringer is in the business or is in the purpose of ensuring that as your patient is going through the stages of life, they are in that car that has been designed to go in rough road, because life is very uneasy for all of us, and most importantly for our patients. So while that patient is on that car that has been designed for the rough road, and the rough road is their diabetes, is their hypertension, is their cholesterol, and all those other intertwined diseases, your patient, we ensure that your patient gets to their destination very safe and very okay. The end destination is what? The end destination is one, an improved quality of life, and two, a happy life. So a happy person is a very energetic person. And most importantly, our patients in our setting. So please join us after the breakout, after the lunch at our table, and we'll be able to expound more on our products. Thank you very much and have a good afternoon.
Thank you. Asante. Can I please have the representative for Ethica, please?
Good afternoon, everyone. My name is Rosemary Ayeko. I represent Etika. Hi, Dr. Acharya. I know you are surprised to see me, and maybe a couple of you. I'm the head of East Africa for Group Etika. Group Etika is an umbrella of multinational companies, and our flagship company is Sanofi, which most of you are very familiar with. Since I'm cognizant of the time that we have, we'll not talk much about our products, but as you all know that Sanofi, we've been here over years in the diabetes space, specifically in Lantus, the insulin glargine. For some of the doctors that I've met when I was a young girl, like Dr. Gaman, Lantus was pretty young. In fact, when you said 2002, I was like, okay, that was the time we used to see Dr. Gaman with a pump, and you were like, I'm really impressed to see that you really carried the vision of the CGMs into the market. Our vision is very simple. We want to drive access for diabetes patients. And I really resonate with the vision of today's conference, the power of connection. I do believe as partners, we also have a role to play in the vision of power of connections, which is to enhance strategic partnerships, specifically in the access arm. And that also resonates very much with Group Ethica's vision. We are not just looking at winning for business, but also to improve patient care and access more. I know we have withdrawn the Lantus Val in the market, but we are looking for ways to improve the SoloStar affordability to more patients in the coming years. So thank you so much. For more interactions, please feel free to meet outside. We are also happy to have sponsored, to have been part of the Platinum sponsors, and we do want to continue partnering with you even in much bigger ways in the future. Thank you so much.
Thank you, Ethica. So we'll be breaking for lunch now. Just a few announcements. You'll find two of my colleagues, chronologists, and
Its silent reach, its complications, and its impact on lives. From screening to prevention, from awareness to advanced care, we have built bridges that heal, and which brings us all together here.
I'm really happy because such forums bring together all different cadres of people looking up to diabetes, nutritionists, diabetes educators, students, doctors, specialists.
And quickly through my topic, which is obesity, insulin resistance, and diabetes connection. There's a lot of information coming up on obesity. And for us as healthcare practitioners, it's important for us to understand how obesity, insulin resistance, and diabetes are connected. So just as a way of introduction, we know that obesity has now been described as a chronic, often relapsing condition that is complex and is of multifactorial origin. And the main characteristic is that it's characterized by an excess of accumulation of fat. we know that it's associated with increased risk of medical, physical, and psychological complications, and it's the underlying factor in majority of the non-communicable diseases and a major cause of death. Once we're able to manage obesity, then we're able to slow down the progression of prediabetes to diabetes, and as well as slow down the occurrence and progression of other complications. So as I've said, the underlying pathophysiology of obesity is just chronic excess of positive energy. So basically you're eating more than what you're putting out, and this tends to lead to excess adipose tissue deposition. So usually the adipose tissue can be deposited in the subcutaneous area, in the visceral area, or in ectopic sites, which we'll talk about later. The excess fat, especially the one that is around the visceral area and in ectopic sites, is what tends to lead to the many of the complications that we know are associated with obesity and sometimes even with diabetes. And this also sometimes will cause a reduction in insulin signaling that will eventually lead our patients to develop type 2 diabetes. So patients who have insulin resistance and insulin hyperinsulinemia can also develop obesity. So it's sort of like a bidirectional thing. You can either have hyperinsulinemia causing obesity and obesity also causing hyperinsulinemia. And often when we describe someone as having insulin resistance, we tend to diagnose them clinically, and the things that we tend to look for is features which may suggest the metabolic syndrome. So we are looking at whether the patient has central adiposity, has diabetes or impaired glucose tolerance, or prediabetes as we call it, whether their blood pressures are raised and have abnormalities in the lipid levels. So these are some of the tests that can be used to assess insulin resistance. They are not very common in our setting. What I think most people tend to do, if at all, is fasting insulin and maybe sometimes the HOMA insulin resistance test. Other than that, these are the ones generally tend to be either difficult to do or out of reach in terms of the complexity of the way they are carried out. So as I've said, obesity is associated with insulin resistance and type 2 diabetes, and usually it occurs as a result of either oxidative stress, inflammation, dysfunction of the adipocytes, endoplasmic reticulum stress, aging, hypoxia, and epigenetic changes. So when you look at the epidemiology, more and more obesity is now being considered as a global pandemic. We are nowhere near managing obesity, but we always say that the time for you to act as a healthcare practitioner is now. So when a patient comes to you in your office, identify that their BMI is above normal and then screen them appropriately. BMI is just a guide. It's like a screening tool, sort of almost like doing a HbA1c or a TSH for probable thyroid disorder. Once you find that, then you would go ahead and do more specific anthropometric measures in order for you to make a diagnosis and classify where they are on the BMI scale. So as the number of people who have obesity increases, so does the number of people who have prediabetes and diabetes. And we know that other than them having these other non-communicable diseases, there are many other conditions that can be associated with excess weight. So things like psychological disturbances. We know people with overweight or obesity are more likely to have issues with anxiety and depression, joint issues like osteoarthritis, even gout, various types of cancer. If you're thinking about ladies, breast cancer, cervical, endometrial cancers, lung cancer. So we can see there are very many conditions that could occur because of excess adipose tissue. So this is just a representation of what we are dealing with globally, that obesity contributes to up to 48% of patients who have type 2 diabetes, up to 78% of cases of hypertension, and 13 plus cases of 13% cases of cancers, with including other conditions. And we know that at least 4 in 5 of patients who are living with type 2 diabetes will have an elevation in their BMI. So we know this is something that we definitely cannot ignore. When you look at dysglycemia, 55% of preventable prediabetes or type 2 diabetes is linked to people who are living with excess adipose tissue or high BMI, and people who develop premature NCD deaths, up to 15% of them have been seen to be associated with the elevated blood BMI. So what are the characteristics? It's important for you to understand the characteristics of adipose tissue. So adipose tissue is not just fat as we know it. There are different kinds of adipose tissue. There is white adipose tissue, pink, beige, and brown. So the two most common ones that we tend to talk about in obesity is white and brown. Pink is there, especially because it's linked to lactation, pregnancy and lactation. So of course it would only be naturally found in women at that time when they have conceived. And beige is like a transitional between white and brown. So essentially what happens is that when conditions are right, then either they would differentiate from white to brown or from brown to white. And we'll talk about this. When we talk about different kinds of adipocytes, white adipocytes are the ones which are associated with higher risks of inflammation if you compare to brown adipose tissue. Unfortunately for us as human beings and as adults, we have a very minimal amount of brown adipose tissue. So metabolic activity is of course reduced, and we know that brown adipose tissue is the one that is associated with weight loss. So we'll see whether there are any therapies that we can use to increase the brown adipose tissue. So as you can see from this representation, there are two main depots for adipose tissue. It could either be subcutaneous or visceral. That could be, it's where the the white adipose tissue is distributed. So either subcutaneously or viscerally. Brown adipose tissue is mainly in the visceral area, and you can see the areas there where it's distributed, and then of course the pink adipose tissue, which is associated with pregnancy and lactation. And you can see the different functions of these different adipose tissues. So white adipose tissue is mainly for energy storage, and brown adipose tissue is mainly for thermogenesis and heat production. So as I've mentioned, main composition of adipose tissue is white and brown adipose tissue. And white adipose tissues characterized by its ability to store and release energy in the form of lipids, which are usually stored, triglycerides, which are stored as a large vacuole in the cytoplasm. So it's at the most abundant tissue found in the body, and as I've mentioned, it's stored either subcutaneously or viscerally, and it is an active endocrine organ. Actually, the adipose tissue is considered one of the largest endocrine organs in the body. It plays a role, other than it playing a role in glucose and lipid metabolism, it plays a role in immunity, in coagulation, and in growth. So you see, it's not just an inactive tissue, it's not just insulating you, it's also playing various actions by release of various chemicals, which we'll talk about later. So brown adipose tissue characterized by high content of mitochondria. Mitochondria is high, so therefore energy production is high, and it has very little lipid droplets in the cytoplasm. It plays a role in thermogenesis by uncoupling respiration, and this occurs mainly in the mitochondria, and it's important in heat production. And in this heat production, it eventually tends to lead to weight loss. So in adults, we've seen by that diagrammatic representation, it's in the interscapular, subscapular areas, and also found in the perineal and periaortic areas. If you compare the distribution of brown adipose tissue in adults versus children, infants and neonates, they actually have a higher amount of brown adipose tissue. So how do we tend to stimulate brown adipose tissue generation? The one that we tend to know of is cold exposure. You've heard of people doing ice baths, isn't it? So that's also one of the way people think that they can tend to lose weight, by that cold exposure, or by activation of the beta-3 adrenergic nervous system. So as I've said, brown adipose tissue has a lot of mitochondria, and in that sense, because it produces a lot of heat, there is also a lot of production of nitric oxide. And what does nitric oxide do to the blood vessels? It causes vasodilatation, isn't it? So when there's vasodilatation, this tends to allow the heat to be dissipated to different parts of the body. When you compare white and brown adipose tissue, because white adipose tissue is more concerned with immunity, coagulation, growth, it has more white cells when you compare it to brown adipose tissue. So as I mentioned, this is the adults versus children. Unfortunately for us, we tend to compare ourselves with mice. So if you compare the infant and the rodent, they almost have a similar amount of brown adipose tissue when you compare it with adults. And then this is just showing the differences in distribution of mitochondria and the differences in distribution of lipid droplets, so that you're better able to understand what is the primary function of these two different kinds of adipose tissue. So adipose tissue is plastic. When you say plastic, it means that it's able to differentiate from one form to another. So white can differentiate into brown and brown can differentiate into white. So what are the conditions? If white differentiates into brown, it's called browning or beiging. If brown differentiates into white, it's called whitening. I mean, it's pretty easy to understand, isn't it? So what are the conditions that would make white adipose tissue differentiate to brown? Cold exposure, as I've said, those people who take those ice baths. Unfortunately, most people cannot tolerate more than 2 minutes, or even 1 minute in an ice bath. So I don't see how practical that is in terms of weight loss, but we'll see. And then, of course, beta 3, adrenergic stimulation. Then on the converse, you can differentiate from brown to white adipose tissue. And white can also differentiate into pink adipose tissue. That, of course, occurs during pregnancy and lactation. So as I've mentioned, adipose tissue is a big endocrine organ, so it produces various chemicals that what we call adipokines. So these adipokines, we know for us who have studied medicine physiology, any kine it's a communicator, isn't it? So they produce various adipokines. So these adipokines could have either beneficial effects or they could have deleterious effects, depending on the nature of the adipose tissue. So we'll go into that slightly. So adipose tissue in obesity, what happens? The number of adipose cells that you have is actually locked in adolescence. So by the time you're maybe past 18, you cannot increase the number of cells you have unless it's a specific, very extreme condition. So what happens? The cells don't increase, but their volume increase, okay? So in the event that you have excess energy intake, your adipocytes will expand. They will not increase in number, okay? So just so you know that that's what happens. Don't lie to yourself that I'm reducing my number of fat cells. So in chronic caloric excess, what happens is hypertrophy, sorry. Hyperplasia has already been arrested at adolescence, isn't it? So they just become bigger than normal. Then when you're starving or fasting, then the size reduces, okay? So unless there's an extreme excess caloric intake, when the storage capacity of the adipocyte is exceeded, in that condition is when hyperplasia can occur. But this is a very rare occurrence, okay? Preferentially, what happens when there is excess of energy intake and the storage is going into the fat, it will first be stored in the subcutaneous adipose tissue. So first stored underneath the skin for insulation, and then if that part is saturated, now it goes to be stored in your visceral adipose tissue. And we know that the visceral adipose tissue is the one we tend to be very worried about. So ladies, don't mind if you have a bit of softness to you, okay? Just as long as you don't have a large abdominal circumference, isn't it? So we can pass with that, even for us, especially for us who are African in origin, isn't it? So visceral adipose tissue and ectopic adipose tissue is the one we're usually concerned with. It's the one that's associated with chronic inflammation. It's the one that's associated with the development of the complications which are associated with some of these conditions. This I've already mentioned. Once the capacity is exceeded, then it goes to the visceral adipose tissue. But what also tends to happen when the capacity is exceeded is that it outstrips the blood supply. So what happens when blood supply is outstripped? Things die, isn't it? So once they die, once these adipose cells are dying, then now that's when they start to produce these harmful adipokines, which tend to attract inflammatory mediators and cause a chronic inflammatory state, okay? So this also happens in various organs. So it doesn't only happen in the subcutaneous tissue because it's going to be stored in ectopic areas. And the ectopic areas that we tend to be worried about are the pancreas, isn't it? The liver, and there's some people are going to talk about muscle D in the workshop, okay? And the muscle, okay? Remember, these are the areas that are very important in controlling blood glucose and lipids in the body. So what happens when it's stored in when that excess fat is stored in the muscle, it leads to insulin resistance because glucose tends to be used by the muscle. But when there is excess fat, it creates a problem such that the muscle cannot absorb the circulating glucose and causes insulin resistance. When it is stored in the liver, what does it cause? Muscle D and MASH. Okay. When it's stored in the pancreas, what does it cause? Prediabetes and diabetes. So you can see all these things are as a result of excess adipose tissue storage in visceral and ectopic areas. So we have two categories of excess weight, what we refer to as metabolically healthy obesity and metabolically unhealthy obesity. So metabolically healthy obesity is just, it's sort of like having prediabetes, isn't it? So it's just like a state of transition before you get to metabolically unhealthy obesity. So in metabolically healthy, person has excess adipose tissue, but they do not have any of those other complications. They don't have diabetes, they're not pre-diabetic, they're not hypertensive. And I'm sure we've met patients like this. They come to you, you see they have excess adipose tissue, but when you check, sugars are okay, BP, they probably even have better blood pressures than you. Okay, so this is just like a state of transition. So this is the point where we tend to see if we can catch these people, because we know if we don't do anything, and as I've mentioned, obesity is chronic and it's progressive and it's relapsing, isn't it? They will probably progress to metabolically unhealthy. So as I've mentioned, metabolically unhealthy obesity occurs when the blood supply is outstripped to the adipose tissue because it is expanding, the cells are dying, pro-inflammatory markers are being produced, and there's a chronic low-grade inflammatory state that has been induced, and this leads now to those complications: impaired glucose tolerance, type 2 diabetes, hyperlipidemia, and hypertension, and eventually cardiovascular disease. So what is the continuum between obesity, insulin resistance, and diabetes? So basically, what underlies all this is that chronic inflammatory state that has been induced by this unhealthy adipose tissue. So what does this cause? This causes immune cells to get into the adipose tissue. The main immune cells that tend to come into the adipose tissue are the macrophages. So these macrophages tend to produce chemicals, and we know the most common inflammatory markers are TNF alpha, interleukin 6. So you find that these inflammatory markers tend now to lead to the insulin resistance developing. Insulin resistance can actually be present for a very long time, even before the patient has developed either prediabetes or type 2 diabetes. So it's important to identify these people before they actually go into those complications. So it's a vicious cycle. Obesity leads to lipotoxicity. Lipotoxicity causes production of reactive oxygen species, which leads to inflammation, insulin resistance, type 2 diabetes, hyperglycemia. So it's just a vicious cycle that goes on and on. Insulin resistance is associated with increased cardiovascular risk. Dr. Samia had mentioned it briefly that patients who have heart failure tend to be at a higher risk of having patients with heart failure and type 2 diabetes have an increased risk of mortality and hospital admissions when you compare to patients who don't have diabetes in the presence of heart failure. But I can tell you heart failure in and of itself is a condition that is also independent of having diabetes associated with increased risk of hyperinsulinemia and insulin resistance. So we tend to find that if you have a subgroup of people who have heart failure, you will find most of them either have pre-diabetes or type 2 diabetes, and that doesn't necessarily mean that the diabetes developed there before the heart failure. So this we've mentioned, excess fat deposition in the pancreas will lead to beta cell dysfunction and eventual glucose intolerance. Then drugs like the TZDs, which act on the adipose tissue, I mean, these are drugs that have been there for a long time, and I think their utility is coming more and more as we discover how their functions are way beyond glucose control. And for pioglitazone and things in that class of drugs, they help in insulin sensitivity and helping also in management of type 2 diabetes and sometimes in patients who have MASLD. So this is just a summary of what I've been talking about: obesity, type 2 diabetes, and insulin resistance. In the pancreas, what happens is that this leads to reduction in insulin production, and interferes with the alpha cells that produce glucagon, and then in the liver causes inappropriate glucose production, and of course increased lipid deposition in the muscle because of excess lipid deposition in the muscles, causes insulin resistance, and then of course the chronic inflammatory state that occurs in dysfunctional adipose tissue. So any organ that produces a chemokine for the purposes of this discussion would be either an adipokine, a myokine, or a hepatokine. Of course, it can be able to communicate with other organs, okay? So because these things not only act in an autocrine way, they can act in a paracrine way and in an endocrine way. So they can act on themselves, on cells adjacent to them, or cells which are far away. So the adipose tissue tends to produce adipokines, the muscles will produce myokines, and the liver will produce hepatokines. So these ones tend to mediate communication with various organs in the system, especially if you consider how the adipose tissue chemokines will communicate with the appetite centers of the CNS and influence appetite. Metabolic syndrome, as we know, because of the increased risk and the increased conditions that are associated with it, has almost 2 to 4-fold increased risk of type 2 diabetes and cardiovascular disease. These are the inflammatory markers that I've mentioned before: interleukin 6, TNF alpha, and then of course the ones that we know are adiponectin, leptin, and myostatin produced from the muscle. And all these, their functions are altered in the state of obesity, and they lead to a chronic inflammatory state. Patients, one of the modalities other than pharmacological management is exercise. I think sometimes we take exercise very lightly, but when you advise, or when your patients, or even you yourselves exercise, you increase production of myokines. Myokines, generally what they tend to do is that they make you more insulin sensitive. So they increase your insulin sensitivity. But if you're sedentary, you're essentially not producing these myokines, and insulin resistance tends to go up. So exercise is not just because I was told in medical school it's lifestyle modification. We can actually see exactly what happens when we advise our patients and give them proper exercise prescriptions. So the liver also communicates with the adipose tissue, as I mentioned, produces the adipose tissue will produce adiponectin, which is hepatoprotective, protects against glucose intolerance, protects against fatty liver disease, and vice versa. The hepatokines will also communicate with the adipose tissue and promote either insulin resistance, inflammation, or insulin sensitivity, depending on whether the adipose tissue or the liver is dysfunctional. Muscle, I've mentioned this about the myokines and exercise. Pancreas, the same, because excess fat tends to also accumulate in the pancreas and affects the production of various chemokines that are produced. The other thing that is coming up is gut microbiota. I don't know whether Betty is here or any dietitian. I think there's a lot of advice nowadays on dietary adjustments that we need to make. But one of the things that we know we need to emphasize for our patients is increased fiber intake. Because if your fiber intake in your diet is reduced, then you get what we call gut dysbiosis. And that abnormality in the gut microbiota also alters the amount of, or rather the nature of the chemicals that these gut bacteria produce. When the gut bacteria are abnormal, they tend to produce chemicals that alter the appetite stimulation in the body. So essentially what we advise people is to eat enough fiber and also eat meals that have short chain fatty acids, so that you can be able to have normal gut bacteria and reduce the risk of development of obesity. So other things that lead to insulin resistance is mitochondrial dysfunction, which I've mentioned, genetic factors. We all know with any kind of non-communicable disease, we always have to consider genetic factors, and stress in the endoplasmic reticulum. So all this is technical, so just for you to know. We know that the adipose tissue and dysfunctional adipose tissue is associated with increased risk of cardiovascular disease, atherosclerotic cardiovascular disease, and the underlying pathophysiology is, of course, endothelial dysfunction. And this endothelial dysfunction tends to lead to inflammation, and inflammation tends to lead to other conditions like hypertension, heart failure, increased risk of acute MIs. So this is just a diagrammatic representation of what I've told you. You can either have functional or dysfunctional adipose tissue, and the dysfunctional one, of course, will lead to complications, which will eventually lead to increasing your cardiometabolic risk when you compare it with functional adipose tissue. So how do we delay diabetes occurrence in patients who may have excess adipose tissue? One, of course, as long as you're able to manage the obesity, for us even who are involved in the care of patients who are living with diabetes, we know that weight management is a consideration when you're prescribing medications for diabetes control, because we know once the patient is able to drop the weight, then you have less requirement for medication and you've reduced their risk for other complications. So as we've mentioned all the time, lifestyle modifications. So diet and exercise, I've already mentioned dietary adjustments and exercise prescriptions, which for our patients with obesity need to be structured. We've said this on and on in various presentations. It's not a blanket prescription. Every patient is unique. So every prescription needs to be individualized because your patients are different. There could be someone who has severe osteoarthritis. I'm not going to go and tell them to do skipping, isn't it? Versus someone who doesn't have severe osteoarthritis. So everything needs to be tailored to the patient who's in front of you. And then, of course, pharmacological management. So pharmacological management, the various medications are available. They are the newer medications, which are the GLP-1 receptor agonist and the other nutrient-stimulated hormone therapies. But our good old metformin is still one of the drugs we can use. In fact, metformin has a little bit of GLP-1 receptor agonist action. So don't forget it as part of your armamentarium in managing patients who have weight. Pioglitazone, as we've mentioned, not just for glucose control, but also for patients who have muscle D. Of course, there are other options which may be more available and better, but for those patients who are not able to access these slightly costlier options, pioglitazone is still an option. Bariatric surgery is an option. I know patients could be afraid of going under the knife, but it doesn't have to be an open procedure. Laparoscopic procedures are also available. Patients can actually be home in 24 to 48 hours after the procedure. So it's not something that needs them to spend a week or even more in the hospital. So what does bariatric or metabolic surgery cause or lead to? Other than weight reduction, it also alters the gut microbiota, especially when you're talking about gastric bypass surgery. So that also alters that internal milieu of the gut bacteria and offers a better favorable gut bacterial profile and helps in weight loss. Okay, so bariatric surgery is a consideration for patients who may be, okay, one, of course, have the means to pay for the bariatric surgery. Two, very high BMI, particularly if their BMI is more than 40 or more than 35 with another comorbidity like hypertension, diabetes, or dyslipidemia, you may consider that. Sometimes we also consider it for people who have a lower BMI, especially if they've tried various methods for weight management and they are not able to lose the weight that they want. Okay. Yeah, so this is just a presentation of what bariatric surgery does and how it alters and helps in not only weight loss, but also metabolic control and also reducing the insulin resistance that patients who have excess weight develop. So the other area that is coming under investigation is browning medication. Remember I said brown fat is associated with increased weight loss, increased heat production. So medications are under investigations which might actually help in increasing the amount of brown fat that we have. So these are just some of the suggested medications that could come up. The area of obesity and insulin resistance it's an ever-evolving field. I'm sure next year we'll see quite a number of new drugs coming up. But for now, what we have, and lucky for us, we have generic options which have allowed a bit more accessibility of these medications to the general public. But I have to mention that these medications should only be given under prescription and by prescription by a trained professional. So someone who's able to go through and evaluate whether the person is a good candidate for the medication, because not everybody is a good candidate, whether there are any contraindications or not, and someone who's also able to follow up these patients closely as they are on these therapies. So other investigational medications and inflammatory medications such as the TNF alpha inhibitors, which we use for various other conditions, like especially in the rheumatology field, but these could possibly be used also in weight management, and toll-like receptor inhibitors, which could also be used. So in summary, adipose tissue is central to the obesity insulin resistance diabetes continuum, and a pro-inflammatory state underlies the mechanism of this continuum and contributes to the complications which are associated with excess weight. Managing overweight and obesity has the potential in reversing complications that may be associated with diabetes and obesity. And lifestyle, pharmacological, and bariatric procedures, they work to reduce the underlying pathophysiological process, and that contributes to disease in excess weight. Thank you.
Thank you very much, Dr. Nicola. I think that was excellent. So when I was giving her to do this talk, everybody's talking about obesity, 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 but we don't think to go beyond and beneath it, at least to see why we are having all these metabolic conditions and the basics of the adipose tissue, insulin resistance. I think she covered it quite well. Thank you so much. Another round of applause for her, please. Yeah. So I think now we move on to the workshop. I don't know if anybody has any burning questions for Nicola. It has to be really burning. I was told there is football. I didn't hear football fan, so I need to hurry up on time. So anyway, in case she's our obesity specialist, in case you have any questions, even I think Mithi is here, obesity. We have many people in the obesity space now. It's now a subspecialty. So you can link up with them. This is about connection. Remember, connect with them. So now I think we'll move on to the workshops. We have 2 workshops. This is mainly a diabetes symposium. So we have to have a workshop on insulin. I think we never get enough of insulin. So we have excellent speakers for our insulin workshop. We have Dr. Saira Sokwala. I don't think she needs much introduction in the diabetes space. Program director, associate professor, she carries so many whatever at the Aga Khan University Hospital. Saira will be there. Dr. Jacqueline Odhiambo, a physician endocrinologist at the Nairobi Hospital. And then we have Dr. Olive Akunga. Why are you hiding? Okay, Dr. Olive Akunga, a physician endocrinologist at the Mata Hospital. So they will be on this side handling the insulin workshop, the practicalities of insulin. So this is a one-on-one. Please don't fear to ask questions you have about insulin initiations, intensifications for your patient, and how to do your insulin carb ratio and all that, yeah? And then on this side, we have, I think Dr. Nicola has touched on it a lot, but we have muscle D. We've always had the complication of diabetes as nephropathy, neuropathy, retinopathy. So now the liver is coming in very prominently, and one of the causes of liver failure now is happening to be diabetes. So we need to put a bit more focus and our microscope on the liver. And so we'll have a muscle D workshop. We have a fibroscan where we will have, I think, a guinea pig. I'm sure he doesn't have muscle D, but we will demonstrate how we do in the clinic. We don't have to send them to the radiology department to do a fibroscan to pick out fibrosis. So there'll be this side. So I'll let you choose whatever you feel is where you need to pick up on more points. For those who want the slides, we can share later on. But we'll be back here at 4. 2 more talks, and then I have some hot bajias, fresh from. Yeah, I'm sorry, Nicola. I know. Let's just whiten the fat a bit today. So let's now at least quickly move on to the various sides that you feel you have interest in, and we meet back.
Wow, you guys are so tired. You're not even reacting. No, I'm just joking. Don't worry. As we come to a close to this year's symposium, delayed reaction. It's like hypoglycemia unawareness. People practice and progress the power of connection. I hope each and every one of you has felt that power, not just in the lectures or discussions, but in the conversations that you've shared over the tea that you've drunk. Grammar matters. The debates that sparked ideas and the laughter that reminded us why we do what we do and why you're here. On behalf of the organizing team, I want to sincerely thank our leadership, supporting teams, and of course for their time and for standing firmly behind us in this vision that came to fruition and making all of this possible. To our delegates and facilitators, thank you very much for showing up with such curiosity, openness, and with all the energy that you'll be able to get after the budgias after this. You are the heartbeat of the symposium, and to our sponsors, of course, we are very, very grateful to you. I'd like to call out the list. That's Boehringer Ingelheim, Sanofi Ethica, Novartis, Beta Health, Cosmos, Dow Life Sciences, Getz Pharma, Q Pharma, Servier, Sun Pharma, Wessex Pharma, Innocia Division. Thank you very much. We are deeply grateful for your continued partnership and support in helping us push the boundaries of diabetes care. Progress, as we've seen, happens when we come together, when we set aside our silos, share our patience, our insights, and sometimes even our frustrations, and to choose collaboration over competition. This morning, as Dr. Kuni has said, it's often just a phone call away. One clinician reaching out to another, one referral made with trust and with goodwill. I hope you're all getting goosebumps. Because you're supposed to. That's what true connection looks like, choosing what's best for the patient, even when it means working across boundaries. We follow guidelines, yes. We strive for excellence, yes. And together we can achieve better outcomes for every person that we serve living with diabetes and everybody else as well. In the future, we look forward to continuing this academic journey with you in the months ahead with even more learning, collaboration, as well as growth. And finally, to everyone here, I hope you have loved not only the academia, but also the food and the fellowship and the spirit of this gathering. Because at the heart of it all is the connection. It's what turns knowledge into care, into power, which helps us progress further. Thank you to each and every one of you. And here's to the power of connection. Bhajias for everyone. Please, please leave at your leisure. Tea is served. I wish you a great evening with wonderful deliberations, a little bit of rest, and of course, the rest of the year. See you at further academic sessions. We have closed. Thank you.
In healthcare is not achieved in isolation, but through the synergy of minds, and there are great minds gathered here today with us.
It is a true pleasure and privilege to welcome you to the 9th Annual Diabetes Symposium. 9 years ago, we began a remarkable journey under the Lions umbrella to establish our multidisciplinary diabetes care centers. But what we began to see was much more than eyes. We were seeing diabetes, its silent reach, its complications, and its impact on lives. From screening to prevention, from awareness to advanced care, we have built bridges that heal and which brings us all together here.
I'm really happy because such forums bring together all different cadres of people looking after diabetes, nutritionists, diabetes educators, students, doctors, specialists, everybody, partners, strategic partners who help us and support us, the pharmas, everybody and anybody who has any interest in looking after the welfare of people living with type 2 diabetes.
Let's share freely, question deeply, and laugh a little too, because innovation happens best when the mind is curious and the heart is light. Let's celebrate 9 years of progress and look forward to many more years of partnership, purpose, and possibility. Together, we are not just managing diabetes, we are reimagining care.
I would like to extend a warm welcome to you all for the 9th Annual Lions Diabetes Symposium. Progress in healthcare is not achieved in isolation, but through the synergy of minds, and there are great minds gathered here today with us.
It is a true pleasure and privilege to welcome you to the 9th Annual Diabetes Symposium. 9 years ago, we began a remarkable journey under the Lions umbrella to establish our multidisciplinary diabetes care centers. But what we began to see was much more than eyes. We were seeing diabetes, its silent reach, its complications, and its impact on lives. From screening to prevention, from awareness to advanced care, we have built bridges that heal and which brings us all together here.
I'm really happy because such forums bring together all different cadres of people looking after diabetes, nutritionists, diabetes educators, students, doctors, specialists, everybody, partners, strategic partners who help us and support us, the farmers, everybody and anybody who has any interest in looking after the welfare of people living with type 2 diabetes.
Let's share freely, question deeply, and laugh a little too, because innovation happens best when the mind is curious and the heart is light. Let's celebrate 9 years of progress and look forward to many more years of partnership, purpose, and possibility. Together, we are not just managing diabetes, we are reimagining care.